Oh, hi, Walt.
Hello, Stephen. How are you?
Yeah, good. Walt, remind us, what time is it where you are?
Oh, it's 10:30. It's 10:30 in the morning. So yeah, I didn't have to get up crazy early for to meet the time needs here, which is great.
Nice, for once.
Yeah, for once, for once. Yeah,
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 yeah. So we're here to chat about your upcoming seminar, but moreover, I mean, we're going to be chatting about skepticism, the tongue. Uh, I mean, there's no end to really what we could discuss here today.
no.
So do you want to start us off down a rabbit hole, and we'll go.
Down a rabbit hole. You know, I'm fortunate enough to I'm at my physical therapy office here in this small little village south of Rochester, New York, and I'm fortunate enough to be able to walk to work in the morning, which I really enjoy. I was listening to a podcast from a friend and colleague of mine, Jamie Johnson, who's a Canadian RMT, and he and Eric Purves run a podcast called the Massage. Let me get this right: the Massage Therapy Development Initiative podcast with Jamie Johnson and Eric Purves. Two very good people when it comes to critical thought, moving beyond the magical thinking of massage, because that's what who they are and what they do, but also the bigger world of manual therapy. And in this particular episode, which I think is episode number 7, they're interviewing Paul Ingraham. Where some of you might be familiar with Paul Ingraham, and in some massage circle, he is the villain. He's seen as the great skeptic of massage and everything we do. And it's like, how did this guy ever get that villainous type of a reputation when all he is doing is calling into question the magical thinking that a lot of us were taught, a lot of us continue to spread, and a lot of the public comes to us with that magical thinking. Right? It's just I only got a chance to listen to the first 10 minutes because it's a short walk in, but it was just spot on for some of the things that I like teaching. And it's almost like we have to teach people to be skeptics, to not simply accept everything that they're given. And whether it's within this manual therapy world or massage world, but in life in general. And one of my roles over the last 10 years was to move on beyond that myofascial release narrative, which involves a lot of magical thinking. And it took me a lot of banging my head against the wall to actually be able to begin thinking critically about the claims made. And it's hard with the public. It's hard with your patient or your clients or whoever you term them, because they come in with these beliefs of what it is that's wrong with them and what it is that we're doing with them. And trying to tease this out, separate the magical thinking, but without tromping on their own values and beliefs. And that's a really fine line because Stephen, if you come in to see me believing that I'm just going to make something up here, that your energy body is involved with all this throat stuff, it's like, is it in our best interest in a therapeutic relationship for me to tell you that you're full of crap, right? When I've not lived your life,
Right.
I don't have your lived experience. I may not believe that your energy body or whatever that phrasing is, and I picked on that, and somebody's probably going to send me an email of hate for that, and I'm good with that anymore. But I may not believe that, and I'd like to transition you into thinking something that is more plausible and logical, but yet I don't know who you are. I've not lived your life, so I want to be careful to allow that. Right. And I think that's where we can align with biopsychosocial. We were just chatting about this before we came online, and some of the problems of the triad of the biopsychosocial model, as well as the evidence-based model. But there's also the lived experience. And that's the one thing that I should not insert myself in and tromp on your lived experience. So I do think it's important that we try to teach ourselves, as well as our patients and other clinicians in my role, the concept of critical thinking. So it was kind of my morning message walking in this morning.
Yeah, that's really interesting, because who gives one a license to critically think? That, because we're sold. I have a bit of a joke of, it's the magic solution for your low back pain or whatever, and it's only gonna cost you $399 plus this massage gun that's $99, and then this free ebook, and so we have this kind of I don't know, the public wants something, or the public may want something, which is the magic wand. which is, I guess, the magic thinking that you're talking about, when
Yeah.
really the evidence supports patient education, a bit of biopsychosocializing practice, patient-centered stuff, and
Right. Right.
exercise and
Yeah.
manual therapy intervention.
And movement. Yeah.
Yeah.
Unfortunately, and again, here comes some more hate mails, but I think that all of us, even when we've transitioned into a more evidence-based model, there's still the silos that we exist in, right? My silo is manual therapy, and other people's silo is it's about breathing. Breathing is the intervention that makes the difference. Other people, it's about the trigger points or posture, or the training, all the training that goes into it, and all of them are simply. I just think they're silos that they're leading us all to a similar path. And where we get sidetracked is thinking that our silo is the silo, instead of just it's like one metaphor, another metaphor to gain that final piece, where it's to give our patients an easier experience, a more quality experience, whatever it is they're walking in our room for, or walking in our seminar for, right? It's like teaching them all these different ways to interact. And it's funny because I realized over the last couple of years that, yeah, I teach manual therapy, but I'm using it as sort of like a tool to teach interactional skills. And I just use manual therapy as my language to interact, teach hopefully a quality interaction with the patient, much as people use exercise or non-touch based, like behavioral training in your world of vocal coaching, etc.
Yeah.
I don't think we're all that dissimilar, even though we wear different hats. It's just really the mechanism in the brain may not be that different, whether you do a vocal coaching or I do a manual therapy intervention. We're still hoping for that spark up here.
And that spark, that connection, that thing is what, getting the patient or the client in their body more? Is it them owning their dysfunction or function? What do you say that when we boil it down, what is that spark?
So, by the way, this isn't a scripted talk we're doing here, so he's making me work. I think basic awareness. You brought the patient's attention to something. You brought your client's attention to something, and whether it's a thing in their tissues that they think we're doing, or something they're doing or not doing, or how they're holding themselves, it's creating that transition from being unaware to aware. Because there's an overused adage that without awareness there's no choice, right? If we can become aware of the feeling or the lack of a feeling, can we then create an opportunity to shift, to change? And to me, that's what manual therapy is about. And all the newer models of manual therapy, it is not about the tissue. Sure, small mechanical changes might be happening here, but it's about the spark that goes up through the nervous system and gives the brain an opportunity to feel what's happening. And I think from a contextual approach that I like to use, that we're giving them that sense of relevance, that my touch is connecting with relevance, and further kind of sparks that interest on their part to see if they can be a creator of change instead of, or at least a partner in change, instead of me being the person who changes things.
And that's about, killing the ego, isn't it? Killing the therapist ego in the room. It's about elevating the patient or the client to an equality or an equity in the relationship. Yeah.
And I think that's a hard one that I'm learning a balance of too, and not squashing clinicians' egos as much as I did in the past, and realizing, everything we do has value. I may not agree with how you approach things, but you don't agree with how I approach things, right? I just think if we can sort of temper our own beliefs in terms of what's wrong and what must be done, and use that as a starting point. It's like, okay, here's what I think is going on, and here's what I think might help, but let's talk about this. Let's negotiate this, instead of me being the dictator, right? The doser, and you the receiver, the passive recipient, because it should be about active engagement. And whether it's an active engagement through movement or exercise, or at least conscious cognitive active engagement, where, okay, he's asking me what I think. And I think that's a novel concept in a lot of therapeutic relationships.
And I think, going on that kind of active versus inactive, we can go for a massage, or massage, as you would call it, and we can go for a manual therapy intervention, whatever. And somebody says, hey, look, how's the pressure? And the clinician, the practitioner might think, hey, I'm being really active in that. But actually, it's a passive active relationship, isn't it? Because they're asking something that doesn't have a useful or quantifiable answer. It's not meaningful. They're just playing lip service to what they feel exists in one of those Venn diagrams, patient preference in the EBM model.
Yeah, I mean, again, giving a little bit more respect for the person who asked the question, I think, it is a really nice starting point. How is the pressure? Unfortunately, it's sort of a closed-ended question. Well, it's good or bad, yes or no, whatever. I like to ask open-ended questions whenever possible, right? And instead of how does this feel, which is usually good or bad, right? I like to ask, what do you feel, right? And really start engaging them right away. How's the pressure? It's a fine question, but how does the pressure should be the first questions instead of the final question, right? Because a lot of people say, how's the pressure? Oh, I'm fine with it. Or the one that I really despise is, oh, I'm fine, I can take it. To me, that's like, well, wait a minute, you can take what? Here's a stick, bite on this while I dig your problem out of you. Often people are willing to do that because we're the expert, right? Oh no, I can do what you need to do. It's like they're stepping back and say, I don't know, I want to remove myself. You do your magic. And while that works, I think it can work better if we step them back from that, if they're willing to step back and say, well, what are you feeling? Does this feel, am I replicating a familiar feeling? Am I calming a familiar feeling? Does this feel useful or helpful, or does it feel potentially harmful or useless? Would you like a little bit more pressure, less pressure? How's the direction? What would you like me to change right now in order to meet your needs right now? That's a lot of freaking work to do when most patients come in expecting us to be able to do our thing and they sort of stay quiet and maybe bliss out or whatever that is that the involvement, the engagement involves. But I hate the sleepers. You're not gonna sleep on my table. And if you are, you're probably not gonna be happy with what I do because I'm gonna keep waking you up. I need to know, is this useful? Does it feel relevant? If not, help me find relevance. It should be about a partnership where the power is pretty much shared equally. Sure, it changes back and forth. It always does in any relationship, but it should be about equality in the therapeutic relation, not about me being the dominant one and you being the passive receiver.
And so, I mean, that's a really interesting kind of segue into some parasympathetic chat. People do report, so if we're talking about lived experience, people do report less pain from just, going to a massage and just zenning out for an hour.
Right.
And I mean, there is value to that in terms of parasympathetic regulation, chilling out people who are in pain, people who have dysfunction. They want that time, or they need that time to down regulate. But there are things in the tongue, there are things in the vocal tract that have these kind of neurotransmission, neuromodulatory things, aren't there? Should we chat about that?
Sure. What is it about what we do that creates relaxation, parasympathetic dominance, rest and relax? I mean, there's probably as many answers as there are people answering the questions, right? Because some might say, well, it's the subtle tones of your wall paint. It's the aromatherapy you use. It's the music you play. I like to say to people sarcastically, it's because I don't have body odor and I dress decent, and all those things contribute to possibly allowing you to feel relaxed. All right. I just had a patient this morning who talked about, I was working around the foot area. I don't have to go into the details, right? But he was saying, I want to just sort of warn you. He said, all my life I've been very sensitive in my feet, very ticklish, right? People couldn't touch me, or I can't even walk on bare feet on things because I'm so sensitive. And he talked about, when people touch me there, I almost like warn them I'm going to kick them. And as we worked through what we were doing, and I was working with his leg and his foot, and I was able to touch the foot. Initially, he was flinching, and then he wasn't. Right? What created that transition from flinching or cringing to basically allowing me to touch his foot in a non-threatening way. And again, one could just have a field day trying to list all the variables, right?
Sure. Yeah.
I was applying touch in a contextually appropriate fashion that was viewed as part of the therapeutic response. I showed him that I wasn't going to tickle him, right? I proved that I was a safe person to be with, and a host of other things, right? Touch, specifically touch has analgesic properties, right? So it could be light touch has a calming of the nervous system or autonomic nervous system effect. It also could be that analgesic property of touch. And there's just so much research out there. When you look into the properties of touch, it's almost like mind-numbing how many different things that we can say touch can be correlated to. Ultimately, I want my touch to be correlated to something that feels useful to you. But getting back to your parasympathetic and your tongue stuff, you know, I've been really on a tongue tangent recently, trying to back off myself in terms of how I treat the tongue, as well as how I teach this work to clinicians when they're treating the tongue. I learned tongue work, and this isn't what I was told in the myofascial release training, is to yank the tongue, right? That's not how I learned it. But when I had tongue work done in seminars and well as by clinicians, there was a level of tension that that I would say was a moderate level of tension that I just viewed as that's how tongue work is done. And over the years of treating tongues and having my tongue treated, which sounds odd, but I've learned to step back from that and then just put it in the manner that I treat the entire body, which is basically the first thing I do when I touch someone is I don't do anything. I simply touch, and whether it's touch externally, touch the tongue, right? By taking hold of the tongue, boy, there's a lot of potential threat at play there. And whether it's, you know, past trauma, past history, or simply, I don't know what this guy's going to do with my tongue. And it often takes a long time for that person to actually, quote unquote, relax. And I've learned the value of simply being before doing, because in many ways, being can become incredibly therapeutic. And just being with that tongue and holding it without pulling it, or when we finally, quote unquote, pull it, it's taking up to that first layer of tension. As I learned in myofascial release, a term called taking up the slack. And while that applied to sort of magical thinking of what the fascia does or doesn't do, I still like that as a sort of an inroad. Let's take up the slack. You're not really pulling, you're just being with and taking it to an endpoint, right? And when you look at the tongue, right, maybe it is muscles we're stretching, muscles we're releasing, or fascia we're releasing, right? The tissue specific. But when you move into the neurodynamic model, right, you've got the hypoglossal nerve, cranial nerve number 12, if I'm not mistaken, right? And you can, via stretching the tongue or engaging the tongue, you can start some neurodynamic technique through the hypoglossal nerve. But then what about, like, what the heck is the vagus nerve doing there, right? The vagus nerve with the, what is it? I got to read this up. I think the palatal-glossus, right? So the vagus nerve provides motor innervation to one of the involved tongue muscles. Now, I'm not a fan of people who claim to be hacking the nervous system or hacking the vagus nerve. I think that's too glitchy and trendy. It's just not my vernacular. But, you know, the whole vagus nerve with, and again, more hate mail, here comes the polyvagal theory and everything that goes along with it. It's a theory for a reason, right? It may be effective, but can we directly impact the vagus nerve? We can't affect anything unless we have a scalpel, okay? But we can take hold of the tongue and possibly have involvement from a neurodynamic technique concept through aspects of the vagus nerve. And sure, it's only a tiny little, you know, offshoot, a branch of the vagus nerve, but could that possibly be why tongue work is often viewed by the patient as somewhat relaxing, even though you've got a hold of their tongue? Could it be? Sure. But it also could be the fact that my walls are a nice color, right? It could be so many different reasons, right? You know, if we're being with that tongue and not threatening the person and their tongue, right? And everything is in the correct context, you're here to help them with a nurturing type of attitude, and potentially overlap into the vagus nerve and in the central nervous system via the neurodynamic technique. I mean, there are just such a myriad of explanations of why our work creates an influence. And maybe it's that, maybe we're hacking the damn vagus nerve. I don't know.
So we're holding the tongue, which is a set of muscle. We're
covered by a set of skin. Covered,
yeah,
right? Yeah.
And I mean, there's, the gauze and the glove and the thing, all in between. So,
Yeah.
the kind of the magic myofascial thing that you and I were both taught of being able to melt and wiggle and, increase flow on the fascia or
Unwind it.
whatever
Yeah.
it, unwind it.
Yeah.
Yeah. That isn't going to happen through a glove and gauze and whatever. I'm thinking about then the tongue as a collective of muscle, the tongue which backs into that whole swallowing mechanism.
Mhm.
What use is there really in breaking anything down into its constituent parts? I mean, is there? Like, if I take apart, we're both wearing AirPods. If we took apart the AirPods, they wouldn't be AirPods anymore, would they? They wouldn't work.
Mhm.
So,
Are you talking about the individual muscles? Like,
I'm talking about muscles, epithelium, the neural stuff. Is there value? Is there any value in looking at anything in its constituent parts for manual therapy?
Well, sure. I mean, we need to know anatomy from a basic safety perspective. It's a good fact. It's a good factor, factoid to know what each of those muscles does, what's its function. From a simplistic way, if a person lacks tongue elevation, you say, okay, that's maybe that muscle, maybe this action, maybe this, whatever, right? And you can go in and you can feel like you're addressing that muscle. Can you address an individual muscle, though, without creating an effect and impact on the patient's skin, right? On the nervous system, on their awareness? Can we treat a muscle in isolation? And this is where I go round and round with people, because people there's still a lot of massage therapists and even physical therapists when it comes to this work are taught it's about the muscle and the muscle action, or their muscle weakness and the muscle dysfunction. And sure, that's relevant, but why is that muscle acting up? Why is it having a problem? Is it simply a little childhood or childish tantrum it's having, right? Is that specific muscle having just a furiously bad day? Or is it the nervous system that is feeding that? Is it the brain that's locked down into a different mode that when we impact that muscle, we're not singularly impacting the muscle. We can't touch the muscle. Sure, we can sometimes isolate it and feel it. It's the great psoas debate, right? Can you touch the psoas? No. Can you feel it? You can kind of feel the outlines if it tenses, but that's a whole nother podcast that we'll do somewhere down the road. I think anatomy is important, but which anatomy are you going to choose, right? Which one is the one that's important? And maybe it's the overlayment of all the anatomy that becomes important. That's kind of the way I view this.
So there is a really strong argument then, if we look at that, for the interdisciplinary practitioner, right? The practitioner who has a layer upon a layer upon a layer upon a layer. So, all of your, how many years? 20 years of myofascial stuff?
30. 29.
30.
Yeah.
Wow. So 29 years of.
And I'm only
42.
I'm only 42. So.
Oh, you do look good for your age, Walt.
Thank you. Yeah.
Okay, so with all of that, that does give you value, right? You talked about taking up the slack, and I seem to remember wait, hold, follow from my myofascial training, which was, you hold out. Well, I don't know why I always go for a cross hand stretch. You hold out, wait, hold, and then.
Well, that's kind of the language that I was taught too. This is how you do it. And there were a lot of rules as to why that's important. I still do this because it's become my language. But when I teach this to clinicians now, they do this and it's like, oh my God, this is the worst. It's just so uncomfortable. It's like, fine, you don't have to do it like that. You can do one hand and break those rules of MFR, but meet the rules of the patient, right? That's where, like, can you separate yourself from the rules and the dogma of what you were taught in order to apply that under the context of a patient-led model? That's what I look for. Sorry if I interrupted you there.
No. That was kind of where I was headed with it, really, because me as vocal coaching Stephen versus me as clinical massage therapy Stephen sees the problem in maybe two different ways, but ultimately I could go at it from a coaching perspective. or a manual therapy intervention and maybe get the same outcome, but maybe a different outcome. But it doesn't matter as long as the person has an outcome that they feel is relevant, beneficial, useful, and that they can walk away and maybe replicate without my hands or my
Exactly.
scales or whatever.
Exactly. Because, when people walk in to see me as a manual therapist, guess what I'm going to give them? Manual therapy, right? I don't have that other hat of vocal coaching like you do. But, I'm almost imagining that you can get similar outcomes in a similar patient by applying those two. How do you rationalize that when you only have one tool? It's that whole thing. When you're a nail, everything, it looks like a hammer, whatever that is, right?
Yeah.
And that's definitely how I view this. That okay, manual therapy is the best intervention because I look at the luck that I'm having. But then the exercise-based therapist has said no. It's all about the exercise. Or unfortunately, they go down that rabbit hole of saying it's because you're weak and you need to strengthen your core and all that. That's those concepts that have really been shown not to be true, even though the public loves it and therapists love to pass it on, right? We all speak a language and we think that the world revolves around that language. And when in reality, it's the commonality of language that helps. And you know what? This is what I do for a living. This is what I teach to clinicians, but I don't teach them that this is the be all end all. It's like, you know what? Can you mix this in with all the good things that you do and, figure out a way to make this recipe work without having to follow a rigid design in order to do that.
Are we moving post-diagnosis? I mean, evidence-based medicine, the evidence-based medicine model, evidence-based practice model has the patient preference in one corner of the triad. It has the best available research in one corner, and then clinical experience in the other. Diagnosis per se doesn't come into that necessarily, right? In terms of manual therapy intervention. So
I think I'm going to stop you. I think there's a wide range of responses there. Everything from the diagnosis is critically important to it's just a description of their symptoms that got them out of the doctor's office and made that doctor able to bill them, right? Somebody comes into me with a diagnosis of cervicalgia, right? M54.2. Okay, they've been given this label of cervicalgia, which basically, if you look it up, it means neck pain with no radiculopathy, with no referral. But what does it really say about that person in terms of the why? It doesn't say a whole lot. Muscle tension dysphonia. It's a starting place for the practitioner. They've ruled out other pathology, all the important things, right? And then, okay, we believe you have muscle tension dysphonia, and these are the interventions which work for muscle tension dysphonia. But it's like I still have to deal with the N of one when they walk in my door because all of the traditional interventions may not impact them or impact them to varying levels. The diagnosis, I don't know, it's a starting point, and I never want to discount that. Number one, because somebody with a lot of education gave that to them, because they ruled out other pathology. And I think that's crucial, especially, as my scope of practice. But if people get too locked into their diagnosis, I think that's an issue too. Is the evidence-based model or some of the dispositional model, is that moving on from the diagnosis? Possibly, but we're still going to need that. That's the way, at least in the United States, how our entire healthcare system is based on the diagnostic model as being the thing that drives the ability for insurer to pay. So it's not going anywhere quickly. Yep.
Sure. Well, our last thing that we've got on our list to chat about is the omohyoid.
Omo-freaking-hyoid.
So
who
invented that?
Was a good idea? Who thought it was a good idea to attach the hyoid to this way back in the scapula? Sorry, go ahead, Stephen.
I was just going to set the scene and say it's one of the 17 muscles of the scapula. I did come up with a little acronym thing to remember all of them, which is the triple S, triple T, brr, cold lip. That's how I remember the muscles that attach to the scapula. And do you know what? I get to the third S and go.
Back in 1982, when I was taking gross anatomy during an entire summer, all of that was meaningful. Now, that's why the internet's there. That's why books are there. I mean, we need to know stuff, but is it important? Okay, sorry. I'm revealing I'm adding a vulnerable side to this that I don't remember all of them. Okay.
Yeah.
But I just think it's so the reason I brought up omohyoid is for the many years is I've been doing work through the anterior cervical region. I teach a technique where we come underneath the SCMs and literally come underneath the scalenes, and you find the landing point of the anterior cervical spine. And from that landing point, you can then explore medially and come in under the thyroid cartilage, behind the larynx. And I just uploaded today a video that Brooke Bielman, who's a speech pathologist, who's taken my work, and she took it. She was being scoped as she did some of the work, and the video is actually quite a bit clearer than the one I posted in the past. But showing you the internal workings of what happens externally when we do this work. But as I've been doing this work over the last decade or so, every once in a while I'll notice something. It's like I don't quite know what that is, and when the patient speaks or swallows, I'll often feel it move. Now, when I say it's like this loose draped rope that often lays in here. And it's like, that's interesting. And okay, so somebody in my position shouldn't be admitting that I'm not quite sure what that was. And finally, I realized that that's where the omohyoid lies. And occasionally we'll be able to actually palpate the margins of the omohyoid. And it's a bizarre muscle, not only because it goes from the lateral aspect of the hyoid to way like over here at the scapula, but it's draped like that. And even though it's contracting, it stays draped. And I think that's just a fascination of human anatomy, right? But, the omohyoid is a depressor of the hyoid. But again, here's a little factoid. It also helps to establish breathing after the active swallowing. And how cool is that, right? It's controlling the hyoid, not just for vocalizations, et cetera, but it's resetting basically the hyoid and establishes breathing after swallowing. So, and I don't know why I brought that up today as a topic of discussion, maybe because we had to fill some time here, right, Stephen? But just this realization that sometimes we can actually go into a space and begin to feel things that we didn't think we were capable of feeling. Is that important? Not necessarily in and of itself. It's nice. It's a nice little, coffee trivia to say I touched the omohyoid on this patient today, right? Does it have impact? That's a whole other question. But to look at some of that bizarre functioning of the voice mechanism, the swallowing mechanism, or the human mechanism in general, when viewed as the whole and not just a muscle by itself, as if somehow it's the fault of what's going on with this person. And that's what you and I have been talking about since you and I met about 3 or 4 years ago online. It's like moving away from that thought that it's about the simplistic aspect of how we were taught and how our patients come in with the expectation, and allowing complexity to be a part of what we do. And the omohyoid is my metaphor for that today.
Brilliant. I love that. Thank you. I didn't know that about the resetting it for breathing. That's fascinating.
I'm going to be honest with you. I didn't realize until last night when I was doing a little peeking around, and I hate to say where I got that factoid from, but it may have been Wikipedia. Yeah.
Wow.
Could have been there. I think it might have been on another anatomy site that was trying to charge me to continue on the website longer than I was. But anyway, I just thought that was an interesting aspect of.
Yeah.
As a physical therapist, when I took gross anatomy, it was about. It wasn't about the anatomy and physiology and action of swallowing and voice and all that, although we sort of touched into that. It was more the PT realm of gross anatomy. And it was it's very, very fortunate to be able to have 4 people per cadaver and really spend an entire summer dissecting that body, right? But it was presented to us under a totally different context. The context of being a physical therapist, but also under the context of we need to shovel all this information into your mouth, and you need to swallow it all and regurgitate it for the test, and then you're allowed to forget it, which is kind of how most of us did it, right? Now I'm able to go back and learn more from the context of where I am at this point in my career, which is really, I enjoy it. I'm having a good time.
It's interesting that you mentioned that. When I was in the dissection lab at King's College a couple of years ago, now, pre-COVID, the surgeon there had been teaching anatomy at King's for 50 years. He was in his 80s, fantastic guy, and was talking about the omohyoid, because we were doing laryngeal dissection, and he was talking about the omohyoid as just a relic of human anatomy, and said how, you know, often one of those infrahyoid muscles, if there's a thyroid removal or any thyroid surgery, one or maybe more of those muscles on one side will be dissected, cut,
Right.
or nicked or whatever. And he said, you know, and then we kind of put people back together and then don't tell them, and normally it's fine because they all work together as one, but also are all overshadowed by the tongue as the kind of great depressor of the hyoid bone. And what, you know, that doesn't matter for most of the population. For expert singers, it's kind of a little bit of a different ball game there, because the tongue might need to be doing something whilst the larynx is doing something else. But yeah, I found that fascinating.
But then, you know, you've got, especially in this area, you've got a lot of built-in redundancy, right? Multiple muscles, multiple, you know, structure, function, having an overlapping function, which is really a good thing, because, you know, if that omohyoid did get nicked, maybe something else can sort of take up the slack. And whether it's that, you know, that peripheral take up the slack or the neuroplasticity of motor relearning, right? But yeah, I would have been in that same camp up until not too long ago, saying, you know, it's a vestige of who we used to be. Do we really need the omohyoid anymore? But you know, it's all playing a role at some point. Is it the major thing that if you know, if you lose your omohyoid, that the larynx or the you can't reestablish swallowing? Probably not, right? But I think it's an interesting factoid which kind of pushed me back on track to say, stop thinking that these things aren't relevant, because everything is relevant. It's just, you know, not as a single entity, but as the greater whole.
On that note,
well, look at you. You got stuff on the band. Look at that.
Wow. You know, you can join Walt and myself. I'm going to be Walt's teaching assistant in London at the Royal College of Speech Language Therapy in June. So it's live on the website, the 2-day Foundations in Manual Therapy for Voice and Swallowing. It's a fantastic class, fantastic. And obviously, you know, you get to meet Walt in person and experience this patient-centered biopsychosocial manual therapy hybrid-ish thing, which is life-changing.
Thank you. Yeah, I'm looking forward to it. Hopefully, you know, borders are going to be, knock on wood, all open again, and really looking forward to coming and teaching again in the UK to a whole new group of people, and maybe some familiar faces coming back to kind of retake the journey again, which is always good. So looking forward to it, and hopefully we'll have a good group of people there, and we'll see where we're at with the mask thing, right?
Yes. Masks, visors, gloves, anti-bac. Yeah.
Exactly.
Look, Walt, thank you so much. Thank you so much.
Thanks for having me as always. And we didn't even get down the rabbit hole of, you know, how to make tea and how to drink coffee and all that kind of stuff. So,
or how you pronounce Birmingham.
Birmingham. I think I've got it. All right. If anybody has any questions, you can contact me from the website. Send me an email, send me a message on social media, because I love to share about what I do, as well as what we're going to be doing in London in a month's time.
Cool. Cheers, Walt. See you later, everyone.